Hey, everybody. Welcome back to the Overrun podcast. My name is Ed Bowder.
I'm Dan Schwester.
And today from the Great White North, we have Dr. Ken Milne. The Bat Doc is joining us again. Hey, Dr. Milne.
Great to be joining you from the North.
Just the regular North. It's April now, so it's not the Great White North anymore. So, Dr. Milne, we brought you on because one of the things, so if you're not familiar with Dr. Milne's work, he is the proprietor of the Skeptic's Guide to Emergency Medicine podcast. Every week they establish a paper or look at a paper, go through the quality of the paper, if they like it or not, if it's practice changing. And it is one of the most important podcasts that you should be listening to if you're involved in EM or EMS. Today, we're going to talk about a couple studies that came out because Ken is way more ahead of the curve than any of us are. And we're also lucky enough to have some studies that Danny actually worked on as well. So we're going to unpack small bags in cardiac arrest. This first paper is, hang on, let me actually make sure I get the screen share here. So we're looking at small bags in cardiac arrest, where this came out. This is out of Resuscitation in December of last year. So, Ken, this paper is association of small adult ventilation bags with return of spontaneous circulation in out-of-hospital cardiac arrest. Dan, let's start with the paper that you talked about, and then I want to hear you and Ken kind of go through this. And how it worked out and what we found.
You know, this is all the new rage in resuscitation, is this idea that a smaller bag gives more anatomically correct tidal volumes and pressures, especially with minimally trained people or untrained people. And everybody's interested to the latest things. It's been very interesting to see if this is actually translating to the real world. I was lucky enough, we actually did a study on this a while back, and we found that it did, but however, it was only on an intubated mannequin, and we were using a Respitrainer, which is a BVM mannequin that measures tidal volumes and pressures. So it was really just kind of a theoretical thing more than anything. And this started to take off and people got interested in it. Now you have manufacturers actually making what they call small adult bags or using pediatric bags in resuscitation. And I'm interested to see, now that this data is coming out, I'm interested to see where that's going with actual patients. Is it making a difference?
And so what we saw here on this paper, and this kind of built off of the research that you did, Danny. So Ken, let's talk about this paper here, small adult bags. Should we be moving to baby bags for everybody? Should we be using large bags? Or the question I like to ask all the time is, do we actually know what the hell we're doing?
Do we know what we're doing? That's a great question. I mean, it feeds science. Like, I have questions about this. And right. I agree with Dan. You know, there's some pathophysiology behind this, and often pathophysiology is very hypothesis generating. It's like, yeah, we think that, you know, smaller or less is more. And you guys know I'm a bit of a minimalist, so, you know, I like to use less things usually. But does a small bag provide a benefit compared to a standard bag? And I wish this study could answer the question, but unfortunately, it's not able to because it's an observational study, and we can dig into that because there's some lessons here.
Absolutely. So we're going through what we actually looked at here in the study. And so for the uninitiated, go through why it's important that it's an observational study and not a randomized control trial or anything like that.
Yeah, sure. I can go through this and set the table here. You know, we're trying to solve this debate about what's the appropriate ventilation strategy. A smaller bag that can deliver a more physiologic volume, and these large bags are delivering too large a volume, so we could be hyperventilating people. Great thought, great hypothesis. So let's test it. They did this retrospective observational study aimed at trying to figure out, are small bags better than big bags or regular bags? And so they set up this study to look at adults with out-of-hospital cardiac arrests. They had to be non-traumatic. And the intervention that they were looking at, or the exposure in this case, was using these small adult bags. And they compared it to the standard ones used by the EMS system. And they set up their primary outcome to be return of spontaneous circulation, or ROSC, at the end of EMS care And then they had some secondary outcomes like the one was end-tidal CO2. Okay. And so in this study, they got close to 2,000 people in this observational study. And as you can imagine, it was older men. So 62 years of age was the mean age, and it was 2/3, 1/3 male, female. So pretty standard population from probably what we're seeing. And about 1 in 5 had a shockable rhythm. And what they found was, dun, 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 the small bag cohort had less ROSC.
What?
And so, yeah, sorry. Should we put a pin on that? Should we just so you heard that correctly, small bags, less ROSC. And this is exactly opposite to the hypothesis and what Dan was talking about earlier with a mannequin study. And so here we have people, and they looked at the exposure to small bags, and they had a 33% ROSC compared to a 40% ROSC with standard bags. So 7% more ROSC. Now, of course, I've repeatedly said this is an observational study, so there's no cause and effect here. And there could be unmeasured confounders, and there could be some selection bias. They didn't measure tidal volume, so they don't know how much they're getting. They did measure, CO2 levels, and tidal CO2, but not how much. They did measure the rate, right, and how fast they were going and stuff like that. But what this tells me is, one, be very cautious about overinterpreting observational studies, no matter which the direction of the magnitude of the effect size. So no matter which direction it's going. Two, the human body, it's smarter than us, right? It might be like, we thought that through, but maybe we didn't think it through far enough. So we don't know still yet. And then in this case, the signal was towards the standard, not the intervention that we were thinking about or the exposure that we were thinking about would be better, the small bags. So really good. And so ultimately what we need is a properly designed, high quality randomized control trial, and maybe a clustered randomized control trial, just so we don't contaminate sites to sites. We're using the small bag on this call, we're using the regular bag on this call. If they had this EMS unit is going to use these smaller bags for the whole department, and this other EMS unit station is going to use the regular bags, and then we can compare so we don't cross-contaminate. And then maybe we'd have a more definitive answer, because we all want patients to get the best care possible and hopefully survival, ROSC, and survival with good neurological function.
That's a couple of things that I got. This study actually had me asking more questions at the end than I got answers. We talk about ROSC, but we didn't talk about survival to discharge. We didn't talk about ventilator days. We didn't talk about length of stay. All of the things that would have shown up with if we had barotrauma, value trauma, things like that we're looking for with these larger bags. It's a good start. And I would say, if you agree with me, observational studies are great to stir discussion, to spur people to doing proper randomized control trials, almost like a proof of concept. Would you agree with that?
Absolutely. I think you hit a lot of really key points there, Dan, that what we're really trying to take away from this is not overinterpret it. This should not be interpreted as small bags bad, but it should be a cautionary tale for, hey, let's not adopt small bags based on observational studies, because this would go against that adaptation. And yes, lots of questions out of this, like, we want to get we want patient-oriented outcomes, not disease-oriented outcomes, but patient-oriented outcomes. It's
the best.
I love it.
Best acronym I've heard all week, Ken.
It's always bathroom humors. It's LOOS, lab-oriented outcomes, DO's, disease-oriented outcomes, or POOs. I guess we could go in the rural area. So SUS, that's surrogate-oriented outcomes. But yeah.
That's a t-shirt idea if I've ever heard one, Ken. But one of the things that I always think is, one of the things I always think is interesting with studies like this, and talking about like the volume, because I remember when we first started talking about small bags, which now is probably a decade ago, because that's how long it takes for research to move into the everyday conversation. Some of the questions I thought were interesting was, we don't know how much air we're actually delivering using a BVM, right? So if I have an adult bag, am I delivering 1,600 mLs of air? If I have a PD bag, am I giving 800? So one of the things that I liked about this study was that, okay, small bags, maybe not the diaspora we thought they were, but large bags also don't necessarily get us, to the higher ROSC rate it gets a higher ROSC rate, but not necessarily the ROSC rate we're looking for. And what I thought was interesting is, just in the data I've been looking at cardiac arrest, there seems to be more and more data coming out where it's like, you know what, this doesn't work, but neither does this. And I want to see some data on like what actually works, what actually improves outcomes. It feels like we're kind of putting out data. We're like, we know that this doesn't work, but do you have confidence or faith that we'll start seeing things come out and be like, actually, this has been superior in cardiac arrests in the past 20 years or so?
So is that question directed at me?
It's kind of just a, yeah. I mean, it's a broad question because
we'd like to solve the world's problems in a 20-minute segment.
Yeah, exactly. Everyone we have come on, we say fix EMS right now. Go.
Here we go. Here's the answer. All right. Recognize that somebody's having a cardiac arrest. Make sure there are people in close proximity that are properly trained to give that first initial treatment. Bystander CPR is so important. And I wish more and more people were trained up in bystander CPR, because that's the bridge between survival to when EMS arrives, and then high quality CPR and BLS when EMS arrives, and that's the bridge to get to the emergency department. So it's like talking about that chain of events and having high quality each one of those things. So my first thing is, if we could have well-trained population around that could respond to these things. And then the next thing is, you're talking about shockable rhythms. These people have to be people that can be saved. And a shockable rhythm is one of the most important things. So that gets me to automated defibrillators in appropriate places. And so where that's likely to happen, I'm up here in Canada. We know that that's the hockey rink. That's the huff and puff we call it. We got middle-aged old guys like me trying to skate around and go, I just want to get one more shift in, right? And so having bystander CPR, so early recognition, bystander CPR, that automatic defibrillator for shockable rhythms, and then getting times down for EMS, right? So in rural areas, I'm always talking about rural areas, getting those time windows down from 30 minutes, 20 minutes, 15 minutes, 10 minutes, down to like 8 minutes, right? So you can have a bridge to somewhere. Because if you don't get a bystander CPR for 10 or 15 minutes, you don't get an automatic defibrillator 10 or 15 minutes, you don't get EMS there in 10 or 15 minutes.
Ball game.
Yeah, it's over, yeah. And certainly we've talked enough about where,
should I use the small bag or should I use the regular bag?
Yeah, right. Exactly. Yeah. Well, and again, that's the thing. It's like this is all good information to know. And we always say, if you've seen one study, you've seen one study. But in the end, we need to have better cardiac arrest workflow, I guess, in society for any of this to really matter. But a little bit pursuant to that, there was a second paper that we wanted to look at today, and this is from SGEM 428. These will all be linked down in the show notes, by the way. So this was talking about using nitroglycerin in right ventricular MIs, which is weird to me because, Ken, I vividly remember being in medic school and being specifically taught that I'm never to give nitroglycerin in right ventricular MIs. So I want you to explain to me why these scientists broke the rules.
Yeah, I'm sure many of your listeners were had that finger wagging. Thou shalt not give nitrates.
No.
Yeah, and that's the thing, and this is a bit of a meta thing. When we have those thou shalt nots and go back and look at the primary literature that informs the thou shalt nots, we realize that we're usually standing on pillars of salt and sand. This caution came from, now it must have been a huge, robust study, right? This was an observational study, single observational study of 40 patients, published in 1989, probably before both of you were born, because I started my research career in 1984, just to give it some perspective, 40 years ago. So this was published almost 40 years ago. And this weak evidence got into the guidelines, and you know what I think about guidelines. They're not guidelines, but it got into the guidelines of the AHA, that's the American Heart Association, and the European Society of Cardiology, recommending against using nitrates in acute MIs if there's right ventricular involvement. And Dan, this goes back to something we were just talking about. There was a pathophysiologic rationale for this. I get it, right? We're trying to think through the problem and going, well, you know, the nitrates, it's going to cause vasodilation that can decrease end diastolic volume and, you know, do all this hand waving. Ultimately, they could get hypotensive, and hypotension in an MI, badness, right? And so it made physiologic sense, right, Dan? Yeah. And so then you've got to go actually out and test it. So this was actually a systematic review and meta-analysis to bring us up to speed on where's the evidence sit now. And unfortunately, they only had 2 studies that they could put together and meta-analyze, and they were both observational studies. One had about 1,000 patients in it, and the other one was a small little study of only 46 patients. And so what they found was no statistical significant difference of adverse events, because that's what they were looking for. They were looking for if the patient was exposed to nitrates by any route and any dose with an acute MI with right ventricular involvement, and compare it to all the other regions of the heart beside right ventricular territory, what was the rate of adverse events? And again, this similar population, these were mainly 60-something-year-old, 2/3 male. And they found no statistical difference with giving nitrates to patients that had right ventricular involvement. No statistical difference in an observational study. Again, we've got to be careful not to overinterpret this. But even those who had adverse events in either of the groups, it was usually transient hypotension, which we know how to treat and we can manage. It was transient and it's something that we could address. So you have some low certainty evidence from only 2 studies, and one was big and one was this little itty bitty, you know, it's so cute, it's this little, and then they put them together. But it's an observational study. So we need to be really careful not to overinterpret and be skeptical about pathophysiologic explanations. But from my standpoint, working in the emergency department, I'm not afraid of giving nitrates to patients with right ventricular involvement, especially, you know, maybe their blood pressure is really high. You know, maybe it's really high. Yeah. Now, if it's soft, I don't care which side of the heart is involved. If they've got a soft systolic, not necessarily giving them nitrates, right? But we need to be prepared for those patients who do get transient hypotensive. But if you're in the pre-hospital setting, you're going to have some protocols. And I hope that this study that we're talking about here stimulates some discussion, Ed and Dan, with the people that are making the protocols for EMS to say, well, maybe we shouldn't have such a prohibition on this.
Yeah. And I think that that's the important thing, right? As data comes out, you want policies and programs to grow and evolve. One of the things, because I remember, I mean, again, this conversation has been out in emergency medicine for, I mean, again, at least a decade. And I remember, you know, you learn like, no, under no circumstances can you do this. And then there's a risk of chart QA and like that. I do hope that this actually gets out so that people can see like, no, you can do this. You can give nitroglycerin to a right ventricular infarct. And also nitroglycerin has a half-life of 2 to 4 minutes. So even if you give a dose in that setting and the patient's blood pressure is affected, you can temporize that pretty quickly, right? We have fluid, we have whatever else. But I do think it's an important find. And I think it's important, you know, we're talking about different things with, you know, cardiovascular emergencies. We always worry about the things that we can't do anything to fix. And I think for a long time, we kind of looked at inferior wall MIs as kind of like, oh, well, off to the hospital we go. And it's encouraging to see that now, you know, there's at least some data that suggests that you can actually treat those patients appropriately. So one of the things that you ask about a lot in the show, Ken, is you mentioned, you know, are these things practice changing? And I think that's kind of an important place to kind of talk about and to kind of end it. I want to know your opinion on if this is going to affect your practice or if this is just stuff to watch over the next couple of years and see what actually grows. And then we'll leave you with the final word.
Yeah, sure. Thanks. I wanted to make sure that people don't get the impression that I ever tell other people how to practice as clinicians. This is just my interpretation of the literature, and they should think about the literature in their own clinical environment. And EMS is a lot of protocol driven, so I'm not encouraging people to break protocol and do those types of things. I would use this as a launching point for starting the discussion and say, hey, have you seen this recent publication? Of course, we're not giving nitrates right now based on our protocol. Should we take this back and reconsider this prohibition on it? And should it be a bit of a softer stance on this? For me, clinically, when it comes to large or small bags, I just want to make sure we have high quality CPR. People are being properly ventilated, and I'm looking at that end tidal CO2. And when it comes to nitrates, again, I'm customizing it. I'm no longer concerned. I got the same finger wagging that you probably did about no nitrates. And I've probably even said, well, we've got to be cautious about nitrates, but this makes me feel a bit more comfortable about giving nitrates. Because again, we don't have a randomized control trial to look to and point to. So it comes back to my favorite answer for any evidence-based medicine question in medicine is it all depends, right? So I'm going to look at this clinical situation with this patient, and I'm going to use the best literature, recognizing that the best literature may be weak. I'm going to use my clinical judgment, and then I'm going to engage with the patient and ask about their preferences and values. Because in that nitro study, they didn't consider the upside, the potential benefits. All they talked about was potential harm. And that's only one side of the coin.
Right. And I think that's right. I think that's a.
No, I was just going to say the overarching lesson I've gotten from the discussion is it's very easy to take a binary view of a paper. It works. It doesn't work. I'm sticking to it. And medicine's not like that. Emergency care is not like that. This is a continuum. It's a gray area. It should influence things. It should not. If you're sitting here and saying, well, I'm doing this because this paper said so, unless it's an amazing paper that's the most perfect paper in the world that proves something beyond a shadow of a doubt, you're missing something.
And can you send me a link to that paper? Because I haven't seen that yet.
Find the perfect paper. Yep.
It's the parachute
that's
one.
the nirvana fallacy, right? Like, oh, you can't do anything because we don't have the perfect paper. Yeah. But yeah, every paper has limitations.
It's the parachute paper from last week where like half the people just took an empty parachute to jump from the ground. But Ken Milne from the Skeptic's Guide to Emergency Medicine,
Definitely.
All of his stuff is going to be in our show notes. Ken, it's been a privilege over these past couple of years to get to know you. Thank you so much for coming on to the show and spreading your knowledge and all of that. We'll be excited to talk to you again. And guys, we'll be right back after this. This episode of the Overrun podcast is brought to you by Team Life. Your hands can save a life. Learning how to perform high-quality CPR can be the difference for someone experiencing cardiac arrest. Team Life offers CPR certification classes throughout New Jersey taught by trained professionals. Sign up today for CPR certification classes at teamlife.com and learn the skills necessary to save a life. Anyone can be a hero. Now back to the show. Welcome back to the Overrun podcast. It's Ed Bowder and Dan Schwester. Dan, that was a really good segment with Dr. Milne. I'm always happy to have him on the show.
Just a great guy, really smart, amazing clinician, somebody we can all learn from, and he's so giving of his sharing his learning and what he's learned with stuff, and just an amazing person.
And this is someone who, aside from that, he's been super generous with his time. He's also been practicing clinical medicine longer than I've been alive. So it's always fun for me in that setting to get some of that knowledge. So let's talk about this small bag thing, because I thought it was interesting. I mean, years ago when we first started talking about the data, and it obviously, we talked about this paper. It doesn't seem like small bags are kind of the solution we thought they might have been. And
we don't know yet.
I mean, we don't.
Hold on.
You're right.
So we've got a couple.
Listen, if you've seen one study, you've seen one study.
One study. So we've got one observational study that showed, well, you know what? When we measure it, smaller bags are more anatomically appropriate because they give a more physiologically appropriate tidal volume. You can't get the pressures too high. It seems like it might work, right? And then we got a couple other people look at it and say, yeah, it seems like it works. Again, observational. Once again, no one has done a randomized control trial on this stuff. Now, this study that we looked at, there's a lot of things that I have questions about that may have impacted the study. First of all, using it on cardiac arrest. If we're really measuring if there's a good outcome, should we measure on breathing patients? Because they tend to leave the hospital. Most of our cardiac arrests are unwitnessed. What was the percentage of cardiac arrests that were unwitnessed here? What was the percentage of cardiac arrests that would reach Opal's criteria, where no bystander CPR, no AED applied, asystolic or PA on arrival? There's a couple others, but basically what they did was basically say, if you have these conditions, this patient's dead. There's nothing we're going to do to get him back. It doesn't matter how much epi you give him, doesn't matter what you hook him to. This is someone who's expired. Again, it talks about an advanced airway. What airway was it? Was it a supraglottic airway? Was it an endotracheal tube? It matters.
Yeah.
It may very well be that for the first line responder who's using a mask, that a bigger bag might be more appropriate, simply because there's going to be mask leakage and there's going to be air that's going to go where it shouldn't go. For an endotracheal tube, very different. Remember, cuff tube in the trachea, all the air that's delivered from that bag is going to go into the tube. That may be different. Once again, none of this has been studied. So we're all making guesses, and the manufacturers, look, God love them. They want to make money. And I love money too, but they're jumping on a bandwagon on one study, and we all do it. We all fall into it. We all have our favorite studies. It's not enough. We've got to keep doing research.
Yeah. And I think, we were always going to keep researching cardiac arrest because it's kind of the whole reason that we're here in the first place. The thing with the bags that I think bugs me is one of the things in this study was they were looking at ROSC at the end of EMS care. Mm-hmm. And something that I always have a problem with is I don't particularly care about ROSC. Like, it's an important statistic. I want people obviously to live when they get to the hospital. But, if I was making this study and instead of looking at bags, we were looking at, say, epinephrine, and it showed that epinephrine increased ROSC, which is really why we're still giving epinephrine today.
Right.
It would just, increasing ROSC means that they're better, which isn't really the case. And, we know with larger, with larger bags, we have the possibility of causing barotrauma and all this other stuff. And we don't really know, what the proper tidal volume is for the patient. More often than not, when we're doing CPR, the patient is supine. So we're going to have to do more work to inflate the lungs. If you have an automated CPR device on them, it's going to make your ventilations a little bit more, like there's so many confounding variables that, while I think that this paper is interesting and I think it gives us a lot to talk about.
Oh, sure.
Again, and like Ken said, I'm not convinced that this is super practice changing, given that it's one study and it's, on a fairly small group.
And it doesn't take away. And here's the other thing that I want to get across is this doesn't take away from the fact that these people did good work. The authors of this paper did something and contributed to the community and actually did a scholarly work that has a benefit. How much benefit? We don't know yet, but it sets a base of evidence for us to study further. Every study, no matter how small, no matter how rudimentary you think it is, right? There's a benefit to it. So my thing to EMS providers out there everywhere is go do a study. Go talk to your clinical people. Go talk to your medical director. Find something that interests you and study it. And you know what? It's great. It's fun. You get to do it. I've done it. You get to get it into you get to get published in a journal. You get to talk about it. People go, oh, well, you're an author. You've done peer reviewed stuff.
You can go and present posters, go to conferences.
Sure, absolutely. Go to conferences, poster presentations. It's awesome. It's a ton of fun. And it doesn't take a lot of work to get into it.
And I think one of the things that certainly you and I have learned over these past, now 6 years doing this show, is more or less, with rare exception, if you have a question about a study, or if you want to work with someone who's doing research or whatever, more often than not, you can probably send an email and usually get in touch with these people. Like it's literally how a lot of this research is done. Is you'll have one data scientist in one organization who's like, hey, I've been working on this data. It seems like it kind of corresponds with what you've been working on. Do you want to work on something together? And that's how some of the better papers come out.
Sure.
So yeah, if you're someone who's interested in data and research and you're not really sure how to find it, ask. You can go around, ask if you're working in an ER, ask one of your EM physicians. I promise you, they know about data and literature, and they probably know about a lot of authors. And again, if this is something that your shop is, not working on, or if they haven't pursued, this is information that you can give to your leadership too, which might end up causing positive change for your organization, which again is always hard to do. And this is something, again, it's one study. So, it's one study where if you're working at a project that has already made the change over to small bags, you can bring this study to them and be like, listen, we might have made this, financial decision, but this might not be the best clinical decision for our patients.
Right. Listen, gang, cathedrals get built one brick at a time.
Yep.
And, 100 years later, you got yourself something amazing,
We don't have 100 years to build a project right now, but we have time.
No, but it's a start. You get what I'm saying.
Yeah.
It all starts, and you have to start with one brick. Like, you can be that brick. You can do that. Like Ed said, ask a question. One of the things, this might be a really good thing for us to do as a training piece or an episode on how to do a study, how to get involved, and we could get some people on to talk about it. It might be really interesting. So watch this space.
Check it out. Now, and talking about that as far as information that might actually change your practice, the other paper we talked about, using nitroglycerin in an RVMI, this is something that I think you can read the study, you can listen to the data, and you can kind of start to apply it right away in these settings. So, and we talked about the paper in the last segment, and it'll be linked in the show notes as well. But when I'm thinking about treating RVMIs, the rationale initially was, well, the right ventricle is low pressure and all that stuff. And if you give nitroglycerin and reduce preload, right.
Blah, blah, blah.
And I've always, to my mind, that's always been like a relative contraindication, right? Like, if it's like, oh, you can't give nitroglycerin with a systolic below 100. Like, well, okay, if it's 99, is that like it's technically below 100, or what if it's 101? Like, it seemed like a very arbitrary kind of protocol and kind of policy to have.
It is. And, I think back to what Dr. Milne said about it is, say you've got this patient with chest pain and you're showing inferior wall, and maybe you do a right side and you've got V4Rs up and you're like, okay, this has got some right ventricular involvement, but their pressure is 180 over 110.
Yeah.
Is this somebody that we really need to be terrified about not giving nitrates to? Or is this somebody that judiciously using IV nitro, where you can titrate it very precisely, or one or two sublingual nitros to lower that and make them not so much systemic vascular resistance that heart has to pump against? Is that going to do better for the patient? And these are the questions that we ask when we're clinicians. This is about knowing your stuff, knowing the tools in your kit, and knowing when to apply them appropriately.
And also having a backup plan, right? So if you're giving nitroglycerin to someone with an RVMI and their pressure, and like I said in the last segment, the half-life of nitroglycerin is only about 2 to 4 minutes. So if you're in a situation where you've given someone nitroglycerin and their pressure bottoms out, it's because you've lessened their preload. So the way you fix it is by increasing their preload. You can give them fluid.
And if you're giving it sublingually, remember, it's only 40% bioavailable. So you're only giving them roughly half of what you think you're giving them. That's what's getting into the system.
And that's assuming that it was given properly and that everything hit the bottom of the tongue appropriately.
Of course.
Yeah. Right.
So, and a lot of times you'll also see, watch the next time you bring a STEMI in to your local facility or your cath lab. I bet you they're going to hang nitro.
Mm-hmm. Every time.
Even if it's 5 mics a minute, 2 mics a minute, they get nitro. I'm telling you, they get nitrates.
Well, but that's another thing to mention, where I think that we sort of default in EMS to thinking about sublingual nitro, where this RVMI paper applies to basic life support providers, but it also applies to ALS providers, where if you have a nitro drip and whatever Trital or whatever you're going to call it, you actually have more control over the medication that the patient is getting than if you're giving them orally. So, and even if, or sublingually, but if you can establish an IV and you have a drip set up on this patient and you're worried that they're infarcting their right ventricle, great, start a drip. If you assume that a sublingual nitro is 400 mics, right? And you're giving them 400 mics every 5 minutes, you can give a drip of 100 mics a minute. It's the same dose, right? You're just giving it IV. And if you're giving it IV, one of the best things about it is if the patient does bottom out, you can just shut off the drip.
Yeah, I mean, obviously, follow your protocols, your medical director's discussions. This is something to bring to them and have a discussion with. That 80 mics a minute is ballparking it. It's not necessarily exact on that. But remember, everything's not binary, gang. There's always applications. Sublingual or IV nitro is so much better than sublingual nitro simply because you can titrate it to a very low rate. You can titrate it to wherever you want it to be. It goes in precisely. You can shut it off on the blink of an eye and you don't have to worry about it. It's something, if you don't have, it's something maybe you should discuss with your medical director, or who does your protocols, because it's an idea that time has come. Sublingual is okay. It's scattershot. It doesn't really do reliable.
Yeah.
It doesn't work as reliably as everybody thinks.
It depends if you're giving a tablet or the spray and how much you gave and
how much absorption, how much saliva is in their mouth. Is there under contaminants in their mouth?
How much was administered through the sublingual route and how much actually hit the buckle route? And
are they naive to it? Have they never had it before, or do they take 2 tabs a day? It's so many ranges of things. It's like, I don't know. I like using IV nitro. In our shop, we use IV nitro. I like it. 50 mics a minute starting is fine. You can go down, you can do 10 mics a minute. You can, if you have a CHF patient, you can do 80 to 100. You can titrate it up as long as their blood pressure stays the same. It works great. And once you're done, you shut it off. It's done. It's over.
Right. And that's not even getting into the value of push dose nitroglycerin for your really sick CHF patients and all that stuff too. So nitroglycerin is something that, nitro's been around for so long that it feels like it's funny to me that in 2020, well, now 2024, we're still debating as to the right way to give it. But I do want to kind of highlight this thing where, essentially one of the last lines in it is adverse events were minor and transient, suggesting nitrates could be a reasonable treatment modality to consider for RVMI based on the current evidence. So this paper came out in February of 23. So now that this paper has been out for 14 months, this is something that should be more, I guess, I don't want to say in the lexicon, but it should be talked about, right? This is no longer brand new data. The reason, rationale, and excuses for not knowing about it are less and less. So you should have leadership that knows about this information about this paper. And you should be able to, have a relationship with your leadership that you can give them this paper and say, hey, maybe we can start to kind of change things a little bit. Maybe we start treating patients a little bit differently. We kind of change our algorithms. There's a lot of stuff that you can do.
Talk to your medical director, talk to your ED physicians, talk to your cath lab people. Ask them what they do. Ask them where they go with it. Take a look at what how they play the game, and you'll be a better clinician for it.
Yeah. And ask what your project knows about these things. There might be a reason or a rationale, or even, in some places there might have been like a legal action that happened X many years ago. And that's why the protocol says what it says. Who knows? There's a lot of mystery over why policies say what they say. But these 2 papers I think are important. They're good to know about. It's good knowledge entering into the summer of 2024. Be sure to link it or like and subscribe for everything on YouTube. The button is down on the bottom of the screen somewhere over in one of these places that we never know where it is. And after that, so make sure you listen to all the rest of our stuff. We had Ken Milne on today. This is great. We've got great stuff with Josh Hartman, Remley Crow, Peter Antevi, Salim Razai, a lot of really good FOAMed leaders on the YouTube channel. So make sure to like and subscribe, comment, let us know what you guys think. And for the Overrun, I'm Ed Bowder.
I'm Dan Schwester.
And we'll talk to you all next time.
Take care, everybody.